So in this chapter, we'll be discussing about the diagnosis of pregnancy. So first, you have certain signs and symptoms of pregnancy. So duration of pregnancy is 280 days calculated from the first day of the LMP. So you have 3 trimesters. So in the first trimester, you have symptoms and you have signs. So symptoms, so basically you can remember it as amenorrhea A, and then you can have bladder for B. So basically in the first trimester, I like to remember it as everything you kind of expel out. So vomit through the mouth, so that is morning sickness, and saliva through the mouth, so that is salivation, and urine through the bladder, so that is irritability of the bladder. So basically amenorrhea. So pregnancy is the most commonest cause for secondary amenorrhea. And again, amenorrhea is highly suggestive of pregnancy. It can occur due to various other reasons such as anovulatory cycles or premature ovarian failure or severe illness or emotional disturbances. Okay, so there could be cyclical bleeding as well in the first 8 to 12 weeks of pregnancy, either from bicornuate or diadelphic uterus. There could be bleeding at the time of implantation, or intermittent bleeding may occur from a normal uterus prior to the fusion of the decidia vera and the decidia capsularis. Okay, and also pathological genital tract lesions can also give rise to bleeding during pregnancy. That can, tell you that it is not amenorrhea, but usually amenorrhea, you can take it as a sign. Next, morning sickness. Again, it starts at around 4 to 6 weeks of pregnancy, continues till 16 weeks, 6 to 16 weeks. Okay, it is usually present in the early hours of the morning and reduces as the day progresses. Okay, though the cause of this morning thing is unknown, it usually coincides with the rising levels of HCG in early pregnancy. So that is why multiple pregnancy or molar pregnancy, the women have higher degrees of vomiting. Okay, and also if it is very severe enough to cause weight loss, dehydration, estenosis, and hypokalemia, ketoacidosis especially, so it is hyperemesis gravidarum. So you need to give IV fluids, correct the electrolytes, give dextrose, all that. Next, excessive salivation is an early symptom of pregnancy. So again, the palate may change, and again, the woman can crave non-edible substances. So that is called pica. And irritability of the bladder, especially because the growing uterus, it exerts pressure on the bladder, and there is frequency of micturition. Okay. But again, when the uterus becomes an abdominal organ, this pressure is relieved and the symptom gradually disappears. Easy fatigability is also there, and headache is also common in pregnancy. You also need to rule out certain neurological conditions if the headache is associated with other symptoms. Next, signs of pregnancy. So first trimester signs of pregnancy, you will have breast changes, obviously. So you'll have general enlargement, prominence of the veins of the breast increase, pigmentation, characteristic primary and secondary areolae. Okay, so the nipples, they become more prominent, erectile nipples. Okay, you have Montgomery's tubercles or follicles. The secondary areolae, they develop from the 12th week onwards. So other changes take place in the first trimester, but secondary areolae, secondary Montgomery's follicles, they occur in the second trimester. So the presence of a little fluid in the breast can usually be detected from 12 week onwards by gently squeezing the breast in the direction of the nipple. Okay, so the fluid is clear and contains some colostrum corpuscles. That's it. Next, you can also have similar changes in people who are using prolactin secreting drugs, or pituitary tumors that secrete prolactin. Next, bluish discoloration of the vagina. This is called Jacquemus sign or Chadwick's sign because there is increased blood flow to the pelvic organs. So you see it especially in the 4th and 8th weeks of pregnancy in the vagina. So the vulva and the vaginal mucous membranes, because of the congestion of these blood vessels, they have a violet or light blue tint. Okay, so this discoloration it increases in intensity up to 16th week and then persists throughout pregnancy. So you'll have Jacquemus or Chadwick's sign. Next, besides discoloration, because of the increased blood flow, you'll have vaginal pulsations also. So that is called Osiander's sign. Next, uterine changes. So the uterus, again, it increases in size. You can detect the fundal height, okay, on examination. Next, appearance. So the virgin uterus is pyriform and it is antiflexed. Then during the first 8 to 10 weeks, the uterus gradually becomes rounded or globular. Okay, position. So sometimes a retroverted uterus does not become anteverted during pregnancy. It remains retroverted. That is when the fundal height is less than what you will expect from the gestational age. Next, size. So the uterus, again, by the 12th week, it starts going into the abdomen. Other changes, the uterus becomes softer during pregnancy, especially in the lower uterine segment in the cervix. You can see, so softening of the cervix, that is Goodell's sign. So then you have something called Hagar's sign. So it is the softening and compressibility of the isthmus or the lower uterine segment, so that is collectively called Hagar's sign. So it is observed from the 6th week to the 12th week of pregnancy. So Hagar's sign, 6 to 12 week of pregnancy. So it is more difficult to recognize in multiparas, easier in primiparas. So basically, Hagar's sign you can elicit in two ways. So especially in women with a lax abdominal wall and a roomy vagina, you introduce two fingers into the vagina. Okay, so behind the cervix, while the fingers of the other hand are pressed down into the abdomen from above. Okay, above the symphysis pubis. So the fingers of two hands almost meet as if there is no resisting tissue in between, and the cervix and the body of the uterus will appear as two different masses. Alternatively, you can pass two fingers into the anterior fornix. The fingers of the other hand are placed above the symphysis and behind the body of the antiflexed uterus, and they're pressed downward to meet the vaginal fingers. Okay, above the uterus, and they go behind and downwards to meet the vaginal fingers. Okay, these manipulations must be gentle, but you don't routinely elicit Hagar's sign anymore because you have ultrasound now. Changes in the cervix. So in a nulliparous woman, you can see the external os is circular, the mucous membrane is smooth and intact, and the os is closed. Okay, and here you can see in women who have a history of premature labor or abortion, or multiparous women, you can find a transverse slit and irregular cicatrices in the cervix. Okay, and also 6 to 8 weeks of pregnancy, you can see Goodell's sign. That is important. So it is softening of the cervix. Next, changes in the cervical mucus. So if you make a slide of the cervical mucus collections, so it shows a beaded pattern characteristic of end effect of progesterone. Next, in the second trimester, you can start feeling quickening. Okay, so fetal movements. So again, morning signs and symptoms that were present in the first trimester gradually disappear. Other signs and symptoms become apparent. So morning sickness, increased salivation, micturition, all of them, they disappear by this time. You'll start feeling quickening, usually around 20 weeks. So 18 to 20 weeks in primiparas, and earlier around 16 weeks in multiparas. Okay, quickening is the first perception of fetal movements by the mother. Okay, based on the date of quickening, an approximate gestational age of the fetus may be arrived at. However, it is not accurate. Okay, because sometimes the mother may mistake peristaltic movements of the intestines for fetal movements. Then you can have pigmentary changes. Okay, so you can have pigmentation, so chloasma, striae, striae gravidarum, linea nigra, and then you can also have palmar erythema and spider nevi, especially in women using especially in hyperestrogenic conditions. Okay, and in non-pregnant women also you can find these findings, especially if they use steroidal contraceptives. Okay, changes in the breasts, again you can have secondary areolae, secondary Montgomery's follicles. Okay, changes in the shape and size, again this uterus keeps growing in size. Intermittent uterine contraction, see in the second trimester, B is the second letter of the alphabet, so you'll have Braxton Hicks sign. Okay, so Braxton Hicks sign and ballotment, that is something I like to remember. Braxton Hicks, ballotment, and again you'll have a lot of colors, so blue or dark, so striae gravidarum, linea nigra, and all that. So basically, Braxton Hicks sign, you'll have irregular, intermittent contractions. Okay, it is detected by palpation as early as week 16. It is there irrespective of whether the fetus is alive or dead. So they occur at long intervals, last for short few seconds. Okay, they occur throughout the pregnancy, and then they're painless. They're not associated with any cervical changes. So active fetal movements. So whenever felt or seen, fetal movements are evidence of continuing pregnancy and a live child. Okay, so they may be seen after the 16th or 18th week. Okay, they may be elicited by external manipulations also. Palpation of the fetal parts. So as the pregnancy progresses, this sign is of great value. Okay, for assessing the position of the fetus also. Then external ballotment. External ballotment, see, internal and external ballotment. Internal from 16 to 18 weeks, and external ballotment from 20 to 24 weeks. Okay, 16 to 18 weeks, what else you can see? Active fetal movements. Okay, you move the child internally and the child also moves internally. Okay, that is how I like to remember. So external ballotment, what you do is basically you put one hand on one side of the abdomen, and you press or basically press and apply some pressure, and then on the other side you can feel the fetus hitting your hand. Okay, so that is external ballotment. It depends on the amount of liquor present in the uterine cavity, and it is difficult to elicit, especially in obese patients or if the liquor is less, so in cases of oligohydramnios. Okay, and in internal ballotment, basically you put two fingers in the vagina and apply upward pressure at the fornix. The fetus goes up and again settles on the finger again. Okay, before week 18, the fetus is too small to respond to the digital impulse, and after week 28, it is too large to even move up and down. Okay, so that is there. And auscultatory signs, so you can also hear the fetal heart first. Basically, that is what you want to hear. So you can use a Pinard's fetoscope. So again, at 18 to 20 weeks. Okay, movement occurs at 16 to 18 weeks, and fetal heart you hear at 18 to 20 weeks. And external ballotment 20 to 24 weeks. Next. So again, it is possible to hear fetal heart sounds using ultrasound Doppler by week 10 itself, but double that 20 weeks by using Pinard's fetoscope. Next, fetal heart rate ranges from 120 to 160 beats per minute. Then you can hear a fetal souffle or a phonic souffle. So basically it is a sharp whizzing sound which is heard rarely, and this occurs because of the rush of the blood through the umbilical arteries. Because of rush of blood through the uterine arteries, you can hear a uterine souffle, which is a soft blowing sound, okay, which is synchronous with the maternal pulse. Then third trimester, basically you can have painless uterine contractions. So Braxton Hicks, again, fetal movements are more easily felt and seen. Fetal parts are more easily palpable. Fetal heart is heard clearly if the fetus is alive. But the ballotment is not elicitable. Okay. Then investigations for the confirmation of pregnancy. So again, first what you will do is, it is based on the diagnosis of beta HCG. Okay. So you have bioassays and immunological tests. So bioassays are obsolete now. Now you use immunological tests. So HCG has alpha and beta subunits. So alpha subunit, it resembles LH also. So if you measure that, you can get a false positive. So that is why you measure beta HCG. Okay. So beta HCG is highly specific. It does not cross react with LH. So you can detect it in the urine and in the blood. So in the urine, you will only do a qualitative assessment, but in blood you can also do a qualitative and a quantitative assessment. Next, so blood, that is more sensitive than urine. So different immunoassays use different combinations of antibodies. Okay. So basically, if you are doing a quantitative test, you are only saying that HCG is present. You can't say whether it is because of pregnancy or because of a normal intrauterine pregnancy or an ectopic or HCG secreting ovarian tumors or gestational trophoblastic disease or non-viable intrauterine pregnancy. Okay. So basically you have ELISA. So what you're doing is, in the test sample, you are using a monoclonal antibody that binds to a HCG in a test sample. So one monoclonal antibody, and you're adding a second antibody which is tagged with an enzyme to sandwich this test sample. Okay. So then when the substrate is added, so the color develops. The sensitivity is 50 milli-international units per ml in serum. Okay. Next, home pregnancy test. So what you do is you use a urine pregnancy test. Okay. So again, urine pregnancy test is most common. You use the first morning specimen. It is usually recommended because the HCG level is highest in that sample. The test can be performed with a random sample also. So again, it uses ELISA principle. Okay. And then the threshold is 25 to 50 milliunits per ml. So serum pregnancy test. Okay, it is the most sensitive method to detect HCG in the serum. See, up to 50 milliunits you are using urine pregnancy, but 1/10 of that, so 5 milliunits also serum pregnancy can detect. So serum tests are useful when pregnancy following ART techniques needs to be confirmed, when ectopic is suspected and all that. Okay. So applications of serum assays, it is more quantitative, right? So you can use something called the doubling time. So the normal doubling time of beta HCG is 48 hours. So in women with missed miscarriage or ectopic pregnancy, missed abortion or ectopic, the doubling does not occur. Okay. That is one thing. Second thing is, see, serum beta HCGs are most often used to confirm pregnancy. And HCG, one thing you need to know is, even pre-implantation, it starts being secreted as soon as there is zygote formation. However, you start to detect it by using your lab methods 8 to 10 days after fertilization. Okay, so it is positive even on the first day of amenorrhea. Okay, or before that also. And then levels of HCG peak at 12 to 14 weeks of gestation, gradually decline. So early high levels, you can think of multiple or molar pregnancy. Then doubling time to for missed abortion and ectopic. And quantitative HCG assays are important in the follow-up of trophoblastic diseases. See, false negative can occur if the test is performed too early or in those with irregular cycles. So you have to repeat the test. False positive can also occur, especially if there is a beta HCG secreting tumor or exogenous HCG administration. Ultrasound diagnosis is currently the most widely used tool to diagnose pregnancy. So the gestational sac is detected as a well-defined white ring, okay, by 4th to 5th week. Okay, so that is important. Here you can see this is oval, right? So it's somewhat like a V. Okay, so that is why 5th week or a 4th week. Okay, so yolk sac appears at 5th week. So while writing a Y, you write like this, right? So Roman numeral 5. Yolk sac appears at 5 weeks. Fetal pole appears somewhat more, so 5.5 weeks. Fetal cardiac activity is detectable at 6 weeks of gestation. Okay, 8 to 14 weeks. Crown rump length you can measure. Next, it takes another 4 to 7 days to visualize all these structures by trans-abdominal ultrasound. Transvaginal, you can do all this earlier. So calculation of estimated date of delivery. So based on the LMP, you can use Nagel's rule and add 9 months plus 7 days. Okay, so go forward, add 9 months and 7 days, or go back, subtract 3 months and add 7 days. And then for women who have had see, this is in this formula you are assuming that the woman has a 28 to 30 days cycle. So if it's a 40-day cycle, so 30 plus 10, so you are adding 10 to the result you are getting from Nagel's rule. If pregnancy falls in a leap year, 6 days should be added. This is important. If pregnancy falls in a leap year, 6 days should be added to arrive at the correct EDD. And then calculate and in irregular cycles and conceiving during lactational amenorrhea or contraceptive methods and all that, EDD determination is challenging. So you can also calculate EDD by clinical assessment. Okay, so the uterus is just palpable at the symphysis at 12 weeks of gestation, and then at the level of the umbilicus it is at 22 to 24 weeks. So see, 12 weeks just above the pubic symphysis, it is palpable in the abdomen. So at the lower border of the umbilicus at 20, upper border 24, then 26, 32, and 36 it is at the xiphisternum, and again it falls back to 32 at 40 weeks. Okay, because of welcome sign and because of flank fullness. Okay, so this clinical assessment also can be used, but duration of pregnancy cannot be accurately determined by this method because of the inconsistency of the location of the umbilicus, the thickness of the abdominal wall, and obesity aberrations, multiple pregnancy, hydramnios, oligohydramnios, etc. So basically, if the fundal height is more than the period of amenorrhea, one thing which is not mentioned here but you need to think of is if you are not doing the fundal examination on a empty bladder. So if the bladder is full, then also the height can increase. Also you can have multiple pregnancies or twins or polyhydramnios, or if there is any accidental hemorrhage which is increasing the fundal height, or any uterine tumor or a vesicular mole. Okay, if the height is less than the period of amenorrhea, it could be an ectopic pregnancy, it could be oligohydramnios, it could be intrauterine death, or the uterus can be retroverted so that it grows more retrovertedly. Okay, or it could be a missed abortion as well. So between 18 and 34 weeks, the fundal height in centimeters equals the gestational age in weeks. Okay, then you can also do ultrasound examination of the gestational age. So basically, crown rump length, so CRL measurement, you can calculate it with accuracy up to 3 to 5 days. So crown rump length measurement is taken along the length of the fetus in a straight line from the top of the head to the bottom of the buttocks without any correction for body curvature. So this measurement is usually taken at 7 to 14 weeks. Okay, so 7 to 14 weeks you do this. So 14 to 24 weeks or 15 to 24 weeks you take the biparietal measurement. Okay, and after 26 weeks of gestation the error increases. Okay, so you do not use it then. Femur length and humerus length correlates strongly with the gestational age. Okay, there is an error of up to 1 or 2 weeks. This correlates again till 26 weeks of gestation. Then the error increases. So differential diagnosis for pregnancy, you can have distended bladder, you can have a fibroid uterus, you can have an ovarian tumor. Then pseudocyesis or phantom pregnancy. See, in women who are badly wanting a pregnancy, ardent desire to become pregnant. So basically, there's a deposit of fat that is seen in the anterior abdominal wall and the omentum, and the intestines become distended with flatus. So the signs of pregnancy may be present. The menstruation may cease, mammary signs may appear, abdomen may become prominent. The woman may imagine that she is perceiving fetal movements. Striae may also appear and all that. Eventually, spurious labor may set in. So again, pregnancy test will be negative. Ultrasound is useful.